So it gives me, as Dean of the College, great pleasure to welcome you to the second annual Richard and Leonora Hill Lecture Series on Frontiers in Vision Research. Those of you who were here last year, remember the inaugural speaker was Dr. David Williams from the University of Rochester, one of our traditional strengths in the area of optics. And this year, our speaker has strength in the area of patient-oriented research, another of our signature kinds of research here at Ohio State. So Dick and Lee, I think we're on a roll in terms of recognizing the giants in vision science, and which I think was your intent in creating this lectureship. So this year's lecturer, Dr. Barbara E.K. Klein, received her medical degree from the New York University School of Medicine and her MPH at the University of North Carolina School of Public Health. She then did a residency in preventive medicine at UNC and then a residency in ophthalmology at the University of Wisconsin, who were smart enough to keep her because she is a professor there in the Department of Ophthalmology and Visual Sciences. Some of you may think, I know her name. What do I know her name from? Well, she is the co-PI of the Wisconsin Epidemiologic study of diabetic retinopathy, a study of retinopathy and other ocular and systemic complications of diabetes, and that has been funded by the National Eye Institute for almost a decade. You're thinking, no, that's not it. That's not what I know her from. Okay, so well, maybe it's that she is the co-PI of the Beaver Dam Eye Study, which is a study of ocular diseases of aging, and that has been funded by the National Eye Institute for 27 years. Okay, that's where I know her from. She and her husband, and I think co-PI, correct, Dr. Ronald Klein, received the Friedenwald Award from ARVO for these studies, and those studies have been instrumental in furthering our understanding of the etiology of those blinding eye diseases, and in also focusing attention on what we might do to prevent them before they occur. She is a prolific scientist and therefore writer. So there are a lot of graduate students here, and graduate students, I want to have you think about something with me for a minute. I think there is a trajectory of recognition that you hope for as you start to write scientific papers. First, it's published. Whether it's in print or it's digital, you're just excited. You know, you want to like send the link to your mom or send a copy of it to your mom, and that's like, oh, that's it, the pinnacle, I had it published. Well, then you kind of want people to maybe read it. Wouldn't that be good, right? Not just that it's published, but that some people actually read it and you have impact. But then the thing that is kind of the coin of the realm in science is when people actually start to cite it. So people start to use it in their papers to say, this is why we're doing what we're doing, and that's where Dr. Klein has excelled. She had, everybody, well, some of you don't, an H-index is equal to the number of papers you have published that have been cited that same number of times, and hers is 85. Any of you who know what yours is? Beauty's multiplying by 2.5. People are doing their multiples, and one of those papers, the prevalence of age-related maculopathy from the Beaver Dam Eye Study, has been cited almost 1,200 times. So she's going to speak to us on the biomarkers for microvascular complications of diabetes. Please welcome Dr. Barbara Klein.
I think I should sit down now because I think you've heard more than the best of what I can say. But I don't know if this is on. Tell me. Can you hear me? I come from Brooklyn. So. I'm sure you can hear me.
This room's kind of a sound sink, actually, so let me make sure.
Okay.
Turn.
I'll try to make sure it's not happening.
Yep. Yeah.
No.
Let's switch to the other one.
Is that one working? I'm not.
Yeah. Now we got it.
I'm more than pleased and very honored to be invited to speak to you today. I'm especially happy to have met both Dr. and Mrs. Hill, and I hope that you come away with a few things from this. I'm going to be talking today not about the Beaver Dam eye study, but this study about diabetes. We have more recent data, and some of this is already on the way, we hope, to be published, to give you a little bit of insight about diabetes, which, as you know, is on the rise worldwide and is likely to be a problem with us, if not forever, then far into the future. So I'm going to talk to you about biomarkers of microvascular disease, in particular in diabetes. Biomarkers are in the news, whatever biomarkers mean, and recently the National Institutes of Health, the Institute of NIDDK, of kidney disease as well as diabetes, has put together a conference and a group, a consortium of people looking at biomarkers for the microvascular complications with an eye, if you want, towards ultimately developing some preventive work measures. So I thought, well, let's define what a biomarker is first. It's a fairly generic word. And I went through the literature and found what the current definitions are, and there are as many definitions as there are people writing them, which is a lot. But in essence, a biomarker can either be a correlate of the disease under study or a surrogate for, and there's a slight difference between the two. A correlate has been shown to have a statistical association with the disease outcome. A surrogate can also be a correlate, but it's thought to be actually in the chain or pathway of disease progress. Good biomarkers indicate the disease presence earlier and more quickly and possibly more cheaper than waiting for the development of overt disease. They're used sometimes to diagnose, stage, or monitor disease, and also are used in clinical trials as a response to therapy before the endpoint or the devastating endpoint occurs. So I've just chosen two relatively recently recognized biomarkers for complications of diabetes. The first one is skin intrinsic fluorescence. What this is that, well, the way it's measured is that light from skin reflectance is measured by a device that I'll show you later, and it's thought to be associated with glycosylation or glycation in the dermal and epidermal layers of the skin. And this has been associated with vascular complications of diabetes, as well as autonomic neuropathy, albuminuria, and some tendon changes amounting to stiffness in tendons. Now, A1C is a commonly used marker, and it's been strongly associated with complications of diabetes. It's a measure of glycemia, but it accounts for only about 10 to 15% of the variance of incident complications of diabetes. There is active research to find biomarkers other than A1C that may account for the unexplained variance. In other words, the other 85 to 90% incidence of disease. So that's why we explored SIF, the skin intrinsic reflectance. This is a photograph of reflectance from a biological tissue after different wavelengths of light are shined on it. And you can see the variation in color. It turns out that that's from a banana skin. But a similar phenomena occur in virtually all live biologic systems. Now, advanced glycation end products are protein complexes formed by the reaction of reducing sugars in the body with proteins, amino acids, or lipids. Now, A1C is a advanced glycosylation end product or glycation end product, but it's of hemoglobin. And what happens is that hemoglobin in the blood, in a non-enzymatic relation with free glucose that occurs that is higher than normal, of course, in people with diabetes, it undergoes a reaction so that they are combined by the double base, let's see, which, not the double base, the double bond, which is shown here, and it forms a more stable compound called the amidori product, which is stable throughout the life of this molecule, which is now glycated hemoglobin. Hemoglobin A1C reflects blood glucose levels over the lifespan of any given red blood cell that's manufactured at that time, and so they may remain in the blood circulation for as low as 120 days. But glucose levels on days nearer to the time of the test substantially contribute more A1C to the overall measure. AGE, or advanced glycosylation end products, have been found by a group of investigators headed by a fellow named Vince Monet. He reported on 10 different advanced glycation end product markers in the skin and found that they were associated with retinopathy, nephropathy, and neuropathy in data from the EDIC and DCCT, or the Diabetes Control and Complications Trial, which you might know is a long-term study of type versus usual blood sugar control in people with type 1 diabetes. And this was true even in spite of adjustment for A1C levels. Now, CIF, the marker that I was mentioning to you, or skin intrinsic fluorescence, can be considered an overall snapshot of advanced glycation end products in the skin. And these may persist longer than A1C does. The data I'm going to present to you come from the Wisconsin Epidemiologic study of diabetic retinopathy. Now, this is the long cohort study that I've been involved with, and we will describe some information derived from the diabetic retinopathy and nephropathy data at a cross-sectional point. We've been following this cohort for incidence and progression of diabetic retinopathy, although we only have the CIF marker at the most recent visit. We followed 996 people with type 1 diabetes who were identified at a baseline exam 33 years ago. And we see them approximately every 5 years. Just to let you know, this is the study area from which we recruited the diabetes patients. This is Wisconsin, as you can see right up here at the top, nestled in between the Great Lakes, and it's red because of Badger Red. And at one time I could tell you it was because we'd gone to the Rose Bowl, but that's been some years ago. Now, the data, as I said, came from the most recent exam, and many of those 996 folks are no longer with us, so it's the survivors of that cohort. As I said before, they were first seen 33 years ago, more or less, 1979 to 1980. We had complete data for all the relevant variables or covariates, and also at least one of the outcomes that I'll talk to you about, as well as the CIF measurements. So CIF is the skin intrinsic fluorescence. We measure it with a device that I'll show you in a minute called the Scout, and it's measured on the underside of the forearm where there's not as much sun exposure. And to account for variations in intrinsic skin color, it takes a measurement of the fluorescence intensity, and that's used as the baseline for that individual, and so the change from that is the measure of the CIF. We measure several different skin intrinsic fluorescence by using different light exposures, although I'll present data from only two because these were the most two informative CIF measurements. I'll show it to you in a moment. This is the CIF device. It's really a pretty nifty thing. It painless, it's non-invasive. The individual sits in the chair, puts his or her arm down on this, and the reading is made. There's a port here for the light exposure to the forearm, and then the reading device is right in there, and information comes up on the screen. So the outcomes that I was interested in talking to you about today are proliferative diabetic retinopathy, which you can see here on this photograph. All of these extra blood vessels, and they are extra, are proliferative diabetic retinopathies. These are very fine blood vessels. They're very friable. A person may have this condition and not know about it, but if these bleed into the vitreous, the person can be blinded immediately. Sometimes it resolves and resorbs, but sometimes not. And sometimes the scarring pulls on the retina and causes a retinal detachment, which is a catastrophic occurrence. The other endpoint is macular edema, that's swelling right in the macular area here, and it can be associated with no symptoms all the way through having severe visual disturbance, because the macular area is the area that's responsible for reading vision. And the other one I'll talk about briefly is diabetic nephropathy, which, as you may know, is another very severe complication of type 1 diabetes. Just to let you know what the definitions that we used were, the severity of retinopathy was graded from stereoscopic fundus photographs. Photographs are now a thing of the past, but at any rate, in the WESDAR, we kept our fundus camera going as long as we possibly could get film. It's not easy anymore. And they were graded using a modified ETDRS protocol. The ETDRS stands for the Early Treatment Diabetic Retinopathy Study, and this protocol was set in place after a large conference called the Early House Conference, and having a standard protocol is important since we use the same standard throughout the study, and this has been used now in most studies of diabetic retinopathy. The endpoint that we're interested in for this analysis is just the proliferative one that I showed you about, or the presence of scars from panretinal photocoagulation, which, as you might know, is likely to make the proliferative lesions essentially disappear, but they only undertake this after the person's already had proliferative disease. Or macular edema, which is judged also in this case from fundus photographs. We did not have OCT at the time. You might know that OCT, or ocular coherence tomography, can pick up more subtle lesions than we can with film. So it's really an underestimate of the present, probably, but it's what we used at the time. And the measure of renal disease is here defined by an estimated GFR, which is taken from the serum creatinine level of less than 60, or the presence of proteinuria, 1+ proteinuria. The other covariates that we considered in these statistical models that we performed were things that we had thought might be related to the outcome given all the other variables that we included. So we considered age, duration of diabetes, mean A1C for over the entire course of the study, over 7 examinations spanning 32 years. We looked at serum triglycerides, current total and HDL, lipoprotein, cholesterol, height, weight, blood pressure, age at onset, medications. Now, not all of those variables were significant in the initial model that we set up. So we examined all of those, and the first model, without the CIF variables that were important in explaining the variance here, the duration of diabetes, systolic blood pressure, HDL cholesterol, triglycerides, smoking, and sex. We forced age and A1C in the model, even if they weren't statistically significant because of our a priori notions that they should be related. And then in the models that I'll show you, we added either CIF1 or CIF15. These are the two variables as I mentioned before, that were most significant in the DCCT study that preceded yours, and we used SAS as standard statistical package. Okay, I want to apologize beforehand for this slide, but I'll walk you through it. This shows the association of the two skin intrinsic reflex factors for proliferative diabetic retinopathy, and I also included here the other variables that were statistically significant in the base model. Now, here we included things that had a p-value that were 0.1 or less. In other words, they didn't have to reach the level that we conventionally consider statistically significant, 0.05, but for example, here we included triglycerides, which was 0.08. And you can see in the base model, before we add in the CIF variables, that in fact, the average A1C over the previous, or over the entire 7 exams, that's 6 previous and the one that we measured at the same time. And you can see that it was 1.93, or quite nearly twice. It increased the risk nearly twice using it as a continuous variable, highly statistically significant, and that was without adding the CIF variables. Model 2 is the one that included CIF1 or CIF01 here, and I highlighted this in yellow so you can see that with all the same variables in the base model, and then the addition of the CIF still was statistically significant with an odds ratio of 1.2, and that was significant. Model 3 substituted the CIF15 instead of the CIF1, and you can see around the same, about 20% increase in its ability to predict risk, and that was significant. So this is risk of proliferative retinopathy. For macular edema, that's the thickening of the macula area, the A1C level, you can see, was actually more important than it had been for proliferative disease. When we add in the CIF variables, neither CIF variable improves on that model. So when we put in diabetic nephropathy, which is also thought possibly be a confounder of this risk, it did attenuate the relationship of the CIF marker to PVR, but it was still statistically significant. When our outcome was nephropathy, that is a decreased estimated GFR or protein in the urine, we found that A1C was less of a factor in predicting it. It was 0.01 in the base model, but it became non-significant once we added in the CIF factors. But the CIF factors, both CIF1 and CIF15, were more informative about nephropathy than about either of the retinal outcomes. So the average A1C is more strongly associated with the retinal outcomes, PVR, and also macular edema, but CIF is stronger for nephropathy. Now you can ask why I included all the past information about A1C, and I did that because I wanted to account, in a way, for the long-term exposure to hyperglycemia over the whole course of this 33 years before, when I only used the cross-sectional value, that is, at the same time I measured the CIF, that was not informative anymore. And I think the reason is because people nowadays are in much better control than they were, and their A1C levels at the time we did this analysis were much, much better than they had been at the beginning. In fact, the average A1C at the time of the cross-sectional analysis was about 7.8 or so, whereas at the beginning of the study, we had glycosylated hemoglobin levels that were as high as 20. It's hard to believe, but that was So, in summary, the findings for this biomarker is that CIP is associated with PPR and with PPR being proliferative retinopathy, as well as mean glycated hemoglobin over all the exams. Nephropathy is more strongly associated with skin intrinsic reflectance than are the retinal outcomes. And the mean glycated hemoglobin does not add significantly to explaining nephropathy. The mean glycated hemoglobin is strongly associated with macular edema, but symptoms. So, what I think with regard to this particular biomarker is that it needs to be tested as a predictor, a true predictor. Now, we would do that if we get follow-up data. We would have another 5 years. I don't know that the study will go on another 5 years, but the sample size is now reduced, and this should be examined in other populations of people with diabetes. But if it is found to be predictive, then it would be worthwhile discussing the possibility of clinical trials to use that as a marker to see if decreasing those levels leads to a decrease in the outcomes. Okay, take a breath. We're going to move on to the second biomarker that I'll talk about today, one that you might or might not have heard about, but that is the retinal vessel diameters, and I'll show you what I mean by that, but it's simply a cross-section through the veins and arteries in the eye. And we sought to explore this because we were looking for another vascular marker that would help be predictive of bad retinal outcomes like proliferative retinopathy or macular edema, and that also might be helpful in predicting the onset of renal disease, diabetic renal disease. In order to do this, we used a program called EIGEN, which was developed at the University of Wisconsin with the help of some engineers and engineering undergraduate students. And then trained graders used this program to measure the width of essentially the erythrocyte column in the retinal arterioles and venules, which approximate the internal luminal diameter. Okay, let me just show you what I mean. So the program EIGEN superimposes these discs, these circular grids here and here on the fundus photograph. It's centered on the disc, and the grader helps to be sure that the centration is correct. And the program then chooses the arterioles and venules and makes these cross-sectional cuts through. This was published in the paper, doesn't matter. But if you leave the program do it itself, the program sometimes makes errors. It doesn't always center it properly, and it doesn't always correctly identify arterioles and venules. That's why the grader must be overseeing this program for it to work. And incidentally, any program that you buy off the shelf that says it automatically picks out drusen or microaneurysms or da-da-da-da is often in error, or at least you have to assume it is. You should never let these programs go on their own. They make mistakes. But it certainly is helpful. It does all those cross sections once you get it right. Then we choose the average diameters of the 6 largest arterioles and venules within that second donut. I'll go back so I can show it to you. It's measured within this area. And the reason why we choose this as opposed to here is because sometimes funny things happen around the disc that are not necessarily representative of the vasculature out here, and they cause some distortion, a little bit more bending, and so on. That's why we use, it's called Zone B. Let's go on from there. So we took measurements from the photographs all the way through in every visit. But what I'm going to present to you was only a limited number of those measures. We took it from each visit because we wanted to see if we could pick up a sequential change. But the data that I'll present to you here are from measurements that were taken at the first visit, 1992, And then the next follow-up visit, and we took the difference between those two. We looked at the change in the diameters of retinal arterioles and venules. And we chose to look ahead a visit after to see if that change was predictive of the development of proliferative diabetic retinopathy. Okay, so is that clear? So we're using it as the change as an indicator of incidence. So first looking at the central retinal arterial equivalent, essentially the average of the 6 arterioles that we measured. And we looked at a 10 micron change over the 4-year period. And we found that there was a slight increased incidence of diabetic retinopathy in people who had that much change, but it wasn't significant. And we looked at here at progression of diabetic retinopathy. In other words, any progression along the scale of severity of diabetic retinopathy. And that did not give us significant information either. However, when we looked at the change in the venular diameter over that period, it was statistically significant. So increased venular diameter appears to be predictive of incident disease that is going from no diabetic retinopathy to any diabetic retinopathy, or for the progression anywhere along the scale. And this has been consistent with, this is one study done in Sweden, but it's been found to be predictive in other studies as well. In fact, when the Ehrlichhaus classification of diabetic retinopathy was put together in 1968, the authors were aware that there were changes in the venules, but they didn't know where to put that in the scheme. And in fact, widening of retinal venules only occurs if you're familiar with that scale, which goes initially used to go from 1 to 60. It wasn't until level 50, fairly severe non-proliferative retinopathy, that they mentioned widening of arterioles, and there it was quite gross, very wide, sausaging, other abnormalities in retinal venules. But because they had no way to measure it at the time, they didn't include more mild or more subtle changes in the venules. So this change we thought might be useful for risk assessment. In other words, to put it into a clinical tool, we wanted to see whether this difference in retinal venular diameter would be useful after we adjusted for the usual suspects. So we developed a risk assessment model, and what that does is to look at the true positive rate of a measure and the false positive rate. Now, if it's not helpful, if any test is not helpful, you'd expect the curve to look something like this, or straight line. If it's very helpful in picking out cases of disease, or in this case, in predicting the development of retinopathy or the worsening of retinopathy, then you would expect this. So that's what this less smooth and less pretty looking graph is all about. This is the risk factor model using the usual suspects, which are change in glycosylated hemoglobin, mean arterial blood pressure, diabetic nephropathy, diabetes type we put in here. We had some information on type 2s, and duration of diabetes. And so you get this curve, and the measure is the area under this, what's called the receiver operating curve. And you can see that the model explains about 0.768. If you add to this model one variable, that variable being the change in the diameter of the retinal venules, you get slightly more, 0.788. These two are statistically significantly different, but they aren't very different. So it adds a small increase. It says the small magnitude of the increase in the area under the receiver operating curve, and what we didn't see is the overlapping 95% confidence level. This suggests that actually it doesn't add very much. And so, with regard to using this as a clinical tool, much as I would like to say it helps, it's really not very helpful. When someone's sitting in front of you as a doc, and you want to give them some idea as to whether their retinopathy is going to get worse, knowing the venular diameter is not very helpful. We also looked at this for kidney disease. And this model is a little different than the other one I showed you, but it's the 4-year incidence. So this is taking the difference over that first interval from visit 1 to visit 2. If there was a change in the arterial or width, you can see that it added nothing at all. It wasn't significant or it wasn't helpful. But using that information, we did find a significant difference for proteinuria. So it helped a little bit in predicting. We didn't do a receiver operating curve on this. We didn't go through the whole process with this. The effect size is also not very big, so it's not very helpful to be used as a clinical tool. So I would say, sort of in summary, that data from epidemiologic studies of retinal vessel diameters have provided a better understanding of the relationship of microvascular changes to ocular and systemic disease in people with and without diabetes. It's been shown in other studies as well. Retinal vessel diameters measured from a photo at a point in time may reflect several things, and it may reflect structural damage to the vessels or just the dynamic physiology that occurs in the blood vessels in the eye in response to local conditions like hypoxia, inflammation, endothelial dysfunction, hyperglycemia, medication status, and probably left out blood pressure, probably very important. So, in summary, data from epidemiologic studies show that changes in retinal, venular, but not arteriolar diameter are independently associated with the subsequent incidence of progression of retinopathy, to proliferative disease and diabetic macular edema. And wider retinal venules are directly associated with the incidence of chronic kidney disease as manifest in proteinuria. There are other studies which suggest also that it's helpful in other measures of renal function. So, from research tool to clinical care, I'd say that finding a statistically significant association between a biomarker and diabetic retinopathy or nephropathy does not provide evidence that it will be a good clinical tool for screening for microvascular disease. We need validation studies to show that when used in patient care, a biomarker provides clinically relevant information that can result in a reduction in morbidity or mortality. And the rest of it is interesting but academic. Thank you. I'm more than happy to answer any questions I can.
In the first part of your talk where you were talking about the skin reflectance, how would you account for the difference in the strengths of association with the different outcomes like retinopathy versus macular edema? Is that just variation, or do you think that sort of represents a different etiology for each of those bad outcomes of diabetes?
Well, I think it has a lot more to do with how we measure the outcome. In other words, for example, I think that we systematically underestimated the amount of macular edema. I think the measures, and across all of these microvascular complications, we actually use a different sort of measure. So for nephropathy, if we use proteinuria or even if we use serum creatinine, those are physiologic measures, and what we're talking about in the eye is a sort of an anatomic measure. So I think there's a difference in scale and a difference in the information we're getting. I think these things are pretty gross, really. I think all we can say is that there's some abnormality that we pick up that we think is associated with it, and that's about all. I can't tell you the severity, reversibility, strength, really the actual strength of the association and what it means. I think about the SIF, that why I think it's in a way an interesting and important marker, even though it's just a correlate of the outcome, is that things that change in the skin, I think, hang around a whole lot longer. I mean, it's probably pretty obvious than glycosylated hemoglobin, or using, if you want, glucose tolerance test. Those are shorter periods of time. And I do think there's something to what Trevor Orchard sort of calls the, what does he call it? It's the glycemic effect over time. And that some way of accounting for the long-term effect of prolonged high glycosylated hemoglobin is probably better, more likely to give you useful information when you're trying to predict risk of something else, of an outcome. And I think that I have been criticized for not using the cross-sectional glycated hemoglobin at the same time that I take the measure of SIP, because that's a true cross-sectional look. But I don't think that it really gives you an indication of the importance of essentially elevated glycemia over the course of the disease. And SIP is imperfect as well. I mean, those things will change in the skin, and I don't know that the skin is the best place to look. It's just that we can measure it.
I don't know enough about SIF, and I think the population in southern Wisconsin is probably mostly Caucasian. Would you expect the same results in people of color as you do in?
That's a good point. Now, John Maynard, who's the guy who designed this gizmo, tells me that's why they take the baseline measure, and they adjust for it. Now, it's probably imperfect as well. I mean, first of all, this part of the arm still gets exposed in many people, and it would depend, for example, on the kind of work you do or the environment you live in. But it's probably better than not taking account of it at all. I don't know how imperfect it is, but you're also right. I mean, the data itself is derived from a Caucasian population, and whether that's, makes it not generalizable, I think is a real question, and I don't know the answer to that.
I was wondering, since you described vessel diameter as being related to hypoxia or endothelial dysfunction, for example, do you think a program like IVAN could be used by professionals regularly who take fundus photographs of diabetic patients? In addition to taking the photograph and analyzing it, and then being able to use a program like IVAN on top of it?
I think, yeah, I mean, yes, you can. One can. That's an available program. Whether it's useful is another story. And I'm not sure it's so clinically useful, but I think it can be done. It's been that measure's been applied to in many studies of cardiovascular disease where they're looking for some kind of macrovascular dysfunction. It's correlated to macrovascular disease. It significantly predicts it, but the other issue is that statistical significance is not all you need to know. You want to know real biologic effect. How important is it? Even for myocardial infarctions where it's significant, it doesn't tell you a lot. So I wouldn't suggest that you do this. It takes a long time to measure these things.
I really enjoyed your talk. I have a question about adaptive optics. And do you think that technology might be able to provide maybe some interesting biomarkers?
I am very ignorant of it. However, being here today, I learned a lot about adaptive optics. And I think that that's going to be a very interesting tool because of its ability to first to look at neurons or neurologically active cells, because the whole issue of which came first, the vascular abnormalities or the neural, I think is still up for grabs. We tend to look at the blood vessels because we can, or we haven't been able to visualize the neural tissue, the important stuff, really, because that's a functional thing, at least in eyes mainly. And I think there's great potential, which I didn't know about before. So I do think that that's going to be a very important tool to try out to assess. If it really, I mean, it has the potential to pick up things even before you can measure anything in any blood vessel. So go for it.
Oh, it was me. I'm curious to know, you didn't talk about any serum biomarkers, but I was wondering if there are any that exist that are fairly specific for diabetic retinopathy or macular edema.
Not that I know of. I mean, the thing that's measured over and over again, of course, is glycemia.
Right.
Some people have been looking at measures, for example, measures of oxidative stress in the serum or endothelial dysfunction. We've looked at a bunch of them. Occasionally one comes in or out. Nothing that's consistent or that's going to be really helpful in a clinical way, at least not yet. You know, what we talked about a little bit this morning, and that is that, or this afternoon, that we tend to measure things we can, that, you know, that are measurable, and also often that we can afford, right? Or what's popular, because that's what the lab will offer. And that might not be the best way to be choosing markers to evaluate. But at the moment, I don't know of anything that's more helpful.
How about genetic markers? I mean, is there any study on genetic markers?
You betcha. I work with a group who's, well, the trouble in my view is that they do GWAS, you know, so it's sort of an agnostic way you spin the wheel, you get a lot of data, right? And then you see, well, is this gene associated with this characteristic outcome? There's actually not much that's come out of that with respect to predicting retinopathy. But as we speak, yesterday I read a paper, it's in draft form, where an investigator has actually found five markers that are, and they're not just genes. She found 5 genes that have that are highly significant. Like she used estimated GFR as a measure. That will be interesting when that paper comes out. I don't know. I know that they're statistically significant to a high degree, but I don't know what their effect size is, which is the other thing that you want to know. I mean, statistical significance, genome-wide significance, is important in understanding that there is a significant effect. But I don't know how common or prevalent those genes are, and I don't know what the strength of the effect is for anyone, which are things that are harder to gauge, but are really, that's the relevant information as well. Not just having a significant marker, but watch for that paper to come out. I think, since it's still making the rounds of a zillion authors, you probably won't see it for another year. But the retinopathy stuff has been pretty disappointing.
And can we use the SIP as like a control measure for the chronicity of the constellation?
You can't use it because it's not yet approved by the FDA. If it is, then I think it's okay to do that because it's a very easy measure. It's not invasive, but also it doesn't give you so much information. It seems to add to the information you get from measuring glycated hemoglobin alone, but it's not a tremendous amount, at least we didn't find it to be. So I'd wait before you bought one of these gizmos if they come on the market for someone to show that it's actually predictive, which I haven't shown. I've just shown a cross-sectional relationship. But if it's not predictive, it's not very important. And even if it is predictive, I don't know what the strength of it will be. So I save my bucks and do a little research first.
Well, you've had a long, distinguished career at, I think, research that people might think was pretty difficult to do. There's a lot of young people in the room. What's your secret, or what advice would you give them?
Well, it's dumb persistence. I think the longitudinal data is important, but you have to believe it, because sometimes I can't always convince myself. Yet, you know, with longitudinal data like ours and the Beaver Dam project as well, after a while, when you start having a significant amount of mortality, unless you're sure the mortality isn't related to the endpoint, you have, you know, less, well, you certainly don't know about the people who aren't there to tell you the story. You do know about the survivors of your cohort, but if that cohort is different in survival patterns than the people in the community, then, you know, you have to question. I tried to check that out amongst the diabetics, not, but in Beaver Dam, just to be sure that I wasn't just looking at a biased group of survivors. And the survivors in Beaver Dam are very much like people in the same age who are not in the Beaver Dam cohort. So all I think I can say about that, and I'm not betting the homestead on this, but I think that influences for people of that age from Beaver Dam will hold up for others, but I can't be sure. And the people with diabetes, I don't know.
So I hear persistence, curiosity, skepticism about your own results.
Oh, skepticism is the most important factor. But I tell everybody is never believe your own results. You're doomed to make terrible mistakes. But if other people repeat it and repeat it, well, maybe.
All right, well, on that note, Barbara, thank you so much.